It won't be.
Worst thing that I can skin on they're going over to San Juan. Yeah, so the guy was driving one of the GPS things, So we're going like 3 miles an hour, and I'm sitting out on the valve, making sure that we don't hit anything. And we turn around, it's like 12 boots. And everybody's like, oh man, we'll let this guy out.
Oh yeah.
Enough underwater, I'm not sure that. It's nice having this directly here.
Yeah. Yeah. People are moving. Is it about 7 o'clock yet?
It's the sign-in code of sign-in.
One diffractor.
What is refractory? How does Drew come up with this stuff? How do you come up with these words, Drew?
I don't come up with them, actually.
Oh, who does?
Kimberly.
Oh.
You can call her
I will. All right, we're ready to get started. Kevin originally wanted to do something else, but then he changed his mind at one point. He was going to do something about pollen identification, which we never discussed, and the only people I think who need to know that are the fellows who have to take their boards and I guess still see some pictures on the exam. But then you changed your mind. Probably this is a more valuable presentation. So, eosinophilic GI disorders. And remember, the way you sign in, is everybody getting to sign in pretty easily? So you have to know the word of the day, refractory. The only other comment is I left some directories out there. This is the next generation directory of everybody in our community. If you take a copy, and everybody in the room, whether you work for industry or you're an allergist or even you don't work like Nick, you're welcome to a copy. Just print your name so I know not to mail it to people. Okay, well, Kevin, go ahead.
I was going to talk about pollen because it does show up on the boards. Excuse me. But Chuck and I are putting together a collection of pictures, so maybe next year. So the talk today is eosinophilic GI disorders, and this is a problem that's been sort of showing up more and more in my clinic. I don't know about other folks. Mostly it shows up as EOE, eosinophilic esophagitis, but I've been seeing a few patients with gastritis and some more distal problems. So I thought it was time to probably start learning about it. I don't have any interest or getting interest. So today,
Make sure you speak up, not only my death. Every week people on the outside tell me that it's not loud.
Is the mic on? Oh, that's not in the room. Okay.
Bring the microphone closer.
Yeah. So today I want to talk about just eosinophils in general, and then a classic eosinophil-based disorders, and then look at the different eosinophilic GI disorders, or EGIDs, talk about both diagnosis and treatment challenges in those conditions, and then maybe finish with some patient resources and some information about legislation going on. So this kind of came to me, this problem landed on my lap with a 17-year-old boy who came in. He had chronic stomach ache, weight loss, and fatigue. Normally he's healthy. He's a cross-country runner. On exam he was thin. He'd been losing weight and trending down on his percentiles. His height was stable, but he had a lot of diffuse tenderness on exam. He had a microcytic anemia on his screening exam, or screening labs, but had normal celiac screen, IgE, and so forth. His primary put him on a PO iron supplement and sent him home. He came back about a month later. It was really no different. And his CBC was no changed. Not changed. So at that point, they sent him to a GI doc, and on EGD, they saw generalized gastritis with prominent inflammatory cells in the lining. That was kind of the limit of the analysis of the biopsy. They said that upstream, the esophagus was normal, and then downstream, the duodenum was also fine. They put him on PPI with the presumptive diagnosis of GE reflux and kept him on the supplement for iron. Another month later, he's still no better. So the idea of food allergy came up, saw an allergist. He had negative skin testing, both to foods and environmental allergens. He had undetectable specific IgE. His total IgE was elevated, and his absolute eosinophil count was 977, so it was elevated. The allergist chose a 6-food elimination diet, empiric avoidance diet. The patient tried it, but he couldn't handle it. It was too hard for him. And finally, they put him on steroid, an oral steroid, and he got better after 7 days. So I guess the question here is, what is his diagnosis? And we talked about things like GE reflux, maybe a food allergy. He has elevated total IgE. He has negative skin testing and negative IgE to specific foods. Is this an inflammatory condition? He has peripheral eosinophilia and this sort of irritation in the stomach lining. And what about something else? Maybe we're missing something that differential here. So questions to sort of think about as we go along in this presentation is, would you recommend topical or systemic therapy for this patient? And if so, how long? And when would you know to stop? Would you do food elimination? And if you did, would you test and how would you choose the foods to eliminate? And then how would you follow this patient over time? Would you use clinical symptoms? Would you do repeat lab tests or maybe even repeat EGD? Knowing all the morbidity that goes along with those things. So these are the eosinophils. We know a lot about these guys, pleiotropic cells. They respond to a lot of different triggers. My favorite description is that eosinophils are like rubberneckers, and they sort of show up at the site of activity and may or may not contribute. So are they an allergic cell? Are they an inflammatory cell? Probably a little bit of both. Do they cause tissue damage, or are they there to help? It's kind of hard to tell. They have a lot of preformed granules, major basic protein, cationic protein, and a neurotoxin. And then in response to certain immunologic signals, they'll actually form mediators at the time of activity. This is just a diagrammatic version of that last slide. Look at that in your handout. So looking at eosinophilia, so as clinicians, we often see this as a presenting complaint. Normally, the absolute eosinophil count should be less than 500 eos per microliter. You can or can't have effects from elevated eosinophils. It really depends on the patient and the condition. When you see hypereosinophilia, often categorized as greater than 1,500 eosinophils, you're going to see more end organ damage, kind of like the HES category. And I saw some authors try to describe mild, moderate, severe eosinophilia, but it doesn't seem to apply when you talk about the real problems when patients have end organ damage, I think. So looking at primary eosinophilia, usually is a malignancy, so myeloid disorders or acute leukemias. In terms of classification of secondary eosinophilia, looking at parasites, particularly as in the worldview, parasites are probably a much larger problem. And in particular, there's a lot of attention towards soil-transmitted helminths. And one of the World Health initiatives is try to, get kids to wear more shoes to try to keep them from getting transmitted through their feet. We see a lot of allergies, medications, connective tissue disorders that cause the secondary eosinophilia, and then, of course, idiopathic. We'll talk more about the workup here in a second. So I wanted to look at eosinophilia with respect to an allergist perspective. So we see HES, we see marked eosinophilia, so greater than 1,500 eosinophils over the course of 6 months. And that's a minimum diagnostic criterion. And then we're likely to see this end organ damage I talked about. And this seems to focus mostly on the heart and the CNS. In Church-Strauss, we'll see patients who have not only a vasculitis of small and medium vessels, but it's more of an eosinophilic vasculitis. And a lot of lung disease, so sort of this asthma phenotype. Then also GI disorders show up with Church-Strauss. I learned about mastocytosis. That was maybe eosinophilia in 20% of cases. That's more than I would have thought. I don't think of eosinophils necessarily with mastocytosis. And then for HIV patients, more mathematically, they have more eosinophils as their CD4 compartment goes down. But also the medications they take can cause eosinophilia, and then just the infections themselves. ABPA comes into play here. This is more of a pulmonary eosinophilia, and it's associated with more proximal bronchiectasis you see with this condition. I reminded myself you see more IgE in ABPA along with specific IgE and IgG to Aspergillus. Now, sorry Gary's not here. I wanted to bug him with this question. So if he's online, he has to guess too. So, of course, this is Pope Francis here. The question is, what's this thingy here? I'll give you a clue. Anybody know off the top of their head?
You know, I just had to stay for my boards.
I'll give you a clue. It's related to this organism. So what's this organism? This is Aspergillus. So this is actually called an aspergillum. The little thing he sprinkles water on people.
Aspergillus?
An aspergillum. I don't know. Okay, so let's talk about eosinophils in the gut. So we do see. Oh well, I was talking about ABPA. Huh? It's medical trivia.
No.
Oh, this guy. So the aspergillum, it's holy water. So he
That's right.
blesses the crowd.
I mean, at least you get blessed before you get sick.
So you do see eosinophils in the GI tract, the spleen, lymph nodes, and thymus. Shouldn't see them in the lung or the skin. We talk about eos being a normal part of the mucosal system and the GI tract, where you see eotaxin actually is expressed constitutively. So there's actually a role for eosinophils, both pro-inflammatory and maybe even anti-inflammatory. We do know that in inflammatory conditions you will see more Th2-style cytokines, suggesting maybe there's more of an allergic phenotype going on locally too. We happen to see more eosinophils in the gut with food allergy than IBD and GE reflux. Looking at the number of so-called normal eosinophils in the GI tract, different authors have different numbers, but from Middleton, at least everyone agrees that the esophagus should have no eosinophils, so that's agreed upon. But the farther down the tract you go, you see more and more eosinophils as you go through the small intestine and the colon. But I think it's important to say that with the esophagus having 0 eosinophils, this is, I think, led to some confusion with early diagnosis of EOE, because I think some people chalked up some of the eosinophils as reflux related, and so it's hard to differentiate reflux from true EOE. So getting to the actual eosinophilic GI disorders, we break them down into sort of 4 large categories, and I think there's really only 3 here. So you have eosinophilic esophagitis, or EOE. You see that a lot. Eosinophilic gastritis or gastroenteritis. And most authors lump those together as just gastroenteritis. They'll say EG or EGE, and then eosinophilic colitis. So these all together think of as an eosinophil-rich inflammation without any other known cause. So there's no drug reactions, infection, malignancies, and so forth. Spergel tried to pin an incidence at 1 in 2,000. I think it's actually very hard to know, although there's increases both in discussion and in cases, like the patient I saw. The fastest rise is probably in EOE, with as many as 1 in 1,000 kids. This author in Gut just described the number of papers that have been available about eosinophilic GI disorders, and it's really on the rise. We know there's probably both genetic and environmental factors going on, so around 10% of patients have an affected relative with an eosinophilic GI disorder. There's probably an allergic component, but I'll sort of say a caveat here that it's probably related to the level of GI tract and also the thickness of the involvement. So 75% of patients are atopic. I'm going to guess the majority of those are probably EOE. We actually broke it down because we don't have the numbers actually differentiate between the different groups. We know that anaphylaxis can occur, but it's not very common. We can reverse the disease process in a lot of cases by just giving an allergen-free or hypoallergenic diet. And that's actually very impressive. We'll talk about those numbers in a minute. Allergy testing may or may not be positive in the setting of these patients. And like I said before, you do see these Th2 overexpression syndromes or phenotypes in patients who have these conditions, even in the setting of negative testing. So in terms of symptoms, you'll see a whole range of symptoms, both functional and pain-related. You'll see patients having vomiting, diarrhea, sometimes gaining weight is a problem, and especially failure to thrive in small children. More suspicious for an EGID if you have refractory GI symptoms, so kind of these chronic patients who don't quite get better. If there's atopy in the history, and then peripheral eosinophilia is a good sign, but it's not necessary to make the diagnosis. About half the cases will have peripheral eosinophils that are elevated. Sometimes it can be at the level of HES, so it can be very impressive eosinophilia. And then lastly, a family history of EGIDs is another sign to be suspicious about. We talked about the differential a lot. Let's get past that. So it's a little pedantic, but comprehensive H&P in the workup. Lab tests looking at CBC with differential. And you need to stop and count the eosinophils. That's often something I've seen not done in primary care. And in the patient I talked about, he actually had high eosinophils, and it wasn't noticed before. IgE levels, look for infections if you think there's suspicion there. I guess you could go looking at skin testing, whether it be prick tests or maybe even patch tests. But that's debated, and we'll get into that. And also an EGD is most likely going to happen for patients who are refractory because you need to get some tissue and understand more. If there's suspicion for HES, in particular very, very high eosinophils, they need to rule that out. And you can look at these lab tests and look at the fusion gene too. That's getting kind of advanced, I think, so you really should have a lot of suspicion before going that far. In general, for these disorders, the treatments range from elimination diets to medications. And we'll kind of talk about the merits and the challenges of each of these different approaches. We've always talked about the 6-food elimination diet, the SFED, and I guess some folks break these out. Break peanuts and tree nuts apart, then shellfish and fish, so now it's 8. Let's start with eosinophilic esophagitis. I didn't want to talk about this today, but it's actually kind of hard to ignore. It's really the hallmark disease in this group of disorders. So we call this a clinical pathologic diagnosis, so you need to have clinical symptoms and lab or endoscopy proof. The symptoms vary by age, though. So in children and infants, you have more of a feeding disorder, vomiting, sort of a reflux appearance. And then in adults and adolescents, you see a lot more dysphagia and food impaction. You'll see eosinophils 15 on high power field is probably what we've all agreed upon now. I haven't really seen much debate about that. Remember, a few years ago, it was kind of like, is it 5, is it 10, is it 20? A word of caution, though, the esophagus can actually be grossly normal on EGD, and I've seen some patients where it was declared normal and there's no biopsy, and the patient really was an EOE patient. And then you also need to prove that the remaining GI tract, both below the esophagus, is still normal. The condition is not due to GERD, and I'm a supporter of a PPI trial, and that's debated as well, because I do believe there is a PPI responsive form of EOE, and of course, well infection, IBD, HES, and so forth. Epidemiologically,
How about treating H. pylori? Is that used also?
That's an interesting question. H. pylori, I didn't really see much discussion in the literature about it in the review articles. I suppose it's worthwhile if the patient's symptomatic. So epidemiologically, we're talking about non-Hispanic, atopic, Caucasians, lots more males than females, and prevalence is there in front of you. Now, is there a genetic source for EOE? Maybe. There are clusters of families where this appears. Some more interesting genetic studies looked at eotaxin 3, so single nucleotide polymorphisms are present in around 14% of cases. A lot more discussion recently about the EOE transcriptome. This is sort of a chunk of DNA that tends to be involved. These gene products tend to be more involved in EOE expression. And then other candidate areas are the 5q22 locus. And then 2 proteins, TSLP and filaggrin, have been associated with EOE. I'm not sure how strong that is, though. So the question is EOE an allergic condition? Well, we know there's associations with both food and environmental allergies. So in one study, 68% of patients had asthma, allergic rhinitis, and then 78 had air allergens, so environmental allergies. Food seemed to keep popping up. So in this study in 2008, 82% of patients had specific IgE to foods. Now, were they allergic to those foods or just have sensitization? That's always the question. Like I said before, many patients have negative allergy tests. So what we have here is this dichotomy between positive testing and negative testing, if they have food sensitivity or not. And then, of course, we get the increased Th2 cytokines.
Is that a pediatric study? What I find is it's almost 2 diseases. Adults have food allergy and kids do. And it's just almost like night and day difference.
Right. That's been my experience as well. I can't remember if these studies were differentiated between kids or adults.
It almost has to be 82% of people skin testing positive, I would think.
Right. And here's just a diagram looking at the various sources for EOE. Here's our air allergens and food allergens contributing. from this direction, and then you have your allergic cytokines, so IL-3, IL-5, Eotaxin. I brought this slide, by the way, from the Tiger, the network that's actually working on eosinophilic GI problems. You've all seen the endoscopy before, so the concentric rings are present. There we go, an A, you get the linear furrows. Here we have a stricture most likely on the way, and then it's very impressive. Just the EGD itself led to this tearing of the very friable mucosa there. In terms of requirements for the microscopy, you need to have a 400 times enlargement, and biopsies from both upper and lower esophagus, at least 2, to make the diagnosis. Let's see. Okay, so how do you manage EOE? This has been talked about a lot. So we mentioned the PPI trial, and I guess the thought there is that if you have any comorbid GE reflux, or if there's a GE reflux / EOE phenotype, at least you can rule it out. There are some authors who say that it's very important to get a trial of PPI and then go from there. That's debatable. Do most people here do a trial of PPI, or sort of curious? Some do. Okay. Yeah. Topical steroids. So we talked a lot about viscous budesonide and then solid fluticasone with various dosing regimens over here on this table for adults, anywhere from 440 to 880 micrograms twice daily, and kids 88 to 440 micrograms. This is curious. I've never heard of a 4 times daily regimen. It's off a lot. And the budesonide is 1 or 2 milligrams per day. There are trials looking at anti-IL-5, the thought being that these are effective in HES, eosinophilic disorder. Maybe they'll work in EOE. These are still in process. Montelukast and cromolyn probably don't have a role here. At least there's no data to support them. And then when all else fails, prednisone is a great backup. And there are times when I'll use prednisone in particularly small children who are in failure to thrive mode, and it kind of helps maybe get them kick-started, cut down the inflammation, and get them healing a little sooner. And in some cases, it may be helpful just maybe psychologically to show them that we can actually do something to stop this disease because they've struggled for so long, food eliminations, or people trying to do allergy testing and not really getting anywhere. That may be helpful. So the question then becomes, is it a disease of dietary elimination, or is it more of a medical management? And so there is no evidence yet to show which is better, whether that's food eliminations or topical steroids. So we know that from background, elemental formulas can normalize this condition in almost all cases. There's been success both in peds and adults, but in the adult cases it's harder because of the quality of life. You can't have an adult on an elemental formula. One challenge, though, practically speaking, is there are patients who require a G-tube for these kinds of feeds. Not only is a lot of morbidity with that G-tube placement and management, but the cost of formula can be very significant. And at the end, if there's enough time, we'll talk about how much it actually costs for families to do these formulas. So we look at targeted dietary elimination as one approach to food elimination. And so this is where you use skin testing. Prick testing has a specificity of only 82% is not too bad, but sensitivity is awful. It's 18 to 88%. So how much can you rely on this test? When we talk about AW patch testing, the specificity and sensitivity are about the same, but in reality, the protocols and the interpretation are not standardized for patch testing. I don't do it. I don't really care for it. That's just sort of my approach. But does anybody do patch testing for foods for EOE here? Sometimes.
David used to do it.
Infrequently. I mean, you're right. I mean, it's not. The results are kind of questionable, right? And I've done it for select patients. I used to do it a little bit more, but now that like you said, it's not standardized, and what do the results mean? I've just done more of an empirical elimination.
Yeah.
So do you just put a drop onto the patch and put it on their back? Do you actually?
It's just for the whole food. I mean, you can have baby food. You can use baby food. It needs to have some consistency. So if you did milk, you can't just put a drop because it'll leak out probably. So you get some milk powder, maybe with a drop of milk, and it becomes kind of a paste. Yeah. But and then they've clearly shown that the specificity and sensitivity for milk patch testing is terrible. So in all these kids, you have them eliminate milk anyway because it's clearly the top food that's been implicated in EOE. So that's why I just end up avoiding milk, wheat, egg, plus minus soy if we're going to do it. Yeah.
There's actually evidence behind that, so we'll get into that in a little while.
If you do it in pen, you your mentors, the people who do it.
Yeah, they still do it regularly, and it's a system. I mean, it's a lot of work involved in a patch test, and I think for our nurses to do it intermittently is kind of tough. At CHOP, they'll still do patch testing. They'll do an extensive amount of patch testing. So they'll do skin prick testing first to common foods in the patient's diet, and if those skin prick tests are negative to those specific foods, then they'll do patch testing. Because clearly, if your skin prick test positive, you don't want to put a patch on for 48 hours. So then they'll use that, regardless of what the skin prick test and patch test shows. They'll still eliminate milk protein.
That's a good point. I mean, actually, just recent studies show just eliminating like 4 foods, or wheat and milk, as good an outcome as any other diet.
Oh, for sure. Kevin's probably going to touch on that.
Touch on that. In my fellowship, we also did patch testing, and it was a lot of work. We used to keep the wet foods frozen in the freezer, bring those out, thaw them out, put them in fin chamber, and then the dry stuff we found things like rice flour and oat flour, potato flours, and sort of put it all together. You try to keep them on those little chambers, it doesn't squish out, and it's just, I was a big fan. And if it's positive, you add stuff like beef or potato or something.
Not to drag this out, but I mean, in a research setting, can't you do lymphocyte transformation studies with this instead of patch testing these kids?
I mean, with food, with the food.
Yeah, well, with anything. I mean, basically, you have a technology that's there,
Right.
and I can't figure out why that's not used in this system.
They don't use it. Yeah, and I don't think at CHOP they really looked into that too much. I have to check.
Well, that wouldn't necessarily prove anything.
Right.
Unless you correlate it to clinical outcome.
Right, but at least, I mean,
Right.
what you're looking for on the skin, I mean, patch tests to me are sort of open to interpretation, even if they're positive.
Right.
So if you have a standardized lymphocyte transformation assay, at least you can get some objective data that it stimulated a specific population of lymphocytes. But I mean, obviously, I'm thinking that nobody's doing it, so it must be a dumb
Foods
idea.
are very complex. A lot of non-specific mitogens come from foods in the first place. Things like, old-fashioned concanavalin and PHA. Those are food extracts, essentially. So they could just be mitogenic responses.
Yeah, it'd just be nice to have some test that actually worked in this disease. So I don't have one.
Well, and I agree with your point. I think sometimes we torture our old tests and make them do things they can't do. And so, as you'll see in these data that are coming up, we're trying to tease out things that may not be there. Anyway, so we're all familiar with the 6-food elimination diet. In a pediatric analysis, they showed that 75% of patients actually got better with just this empiric elimination, and then 73% in an adult analysis. These were small studies, but they sort of got the ball rolling about this idea of just empirically pick the higher risk foods and then skip the testing. When they reintroduced the foods, most often it was wheat, milk, soy, nuts, and egg that were the problem foods. And this is through a lot of work. This was repeat serial endoscopies, so putting kids out, doing EGD, biopsy, reintroduce the food, bring them back in 6 weeks. And so it's not practical. I don't think it's really that safe, in my opinion, knowing all the morbidity that comes along with putting kids under sedation. And then compliance and quality of life are major issues with these empiric eliminations. I will say, though, a lot of families are very attracted to this idea because of the steroid-sparing nature. So, I mean, my families I see are somewhere between averse and highly averse to steroids. And so many of them will go down this route. But I try, like Dave said, I'll try to cut down the number of foods that they're eliminating. This next study was actually published about a year ago, and I talked about it in this Journal Club last year. But at Northwestern, Kagawala just decided, hey, let's avoid milk only. Having seen the data that milk reintroduction tends to be the worst player, what happens if we just eliminate milk and do nothing else? Skip testing, skip all the rest of the foods. And in a very small cohort, they had around 65% improvement. And I'm very curious to see what happens the rest of the study when they actually publish the data. So in this study by Henderson, also from last year, this was a retrospective study looking at kids. They were EOE confirmed with eosinophils and had failed PPI trials. So they looked at these different dietary approaches. It was not randomized because it's a retrospective study, but they said, okay, the patients who got better on histology, how did these different approaches work? So if you look at elemental diets, as we know, they do very, very well. 96% of patients got better. With the 6-food elimination diet, 82% resolution. This is 6-food elimination diet plus the results of skin or patch testing. not much different than just guessing or educated guess. And then the most discouraging for allergists is that skin prick and patch testing got us only 65% improvements. And so as they reintroduced foods, they saw that milk was by far the biggest culprit. I think this is where the Kaggle-Wallace study came out, or at least the small study was inspired. So one of the questions here is, what's our role if test-directed diets are not actually that impressive, and if you can just make an educated guess?
How many of those studies had controls?
Well, again, these are retrospective, and so that's the problem. Yeah. And likewise, this study does kind of the same thing. They look at patients in retrospect. They happened to look at patients with EOE, and then they did a directed and then also standard panel of prick tests to meats and so forth. And of course, milk came up again, egg, wheat, soy. Interesting combination, so a lot of milk-only patients, milk plus meat, and then milk, egg, wheat, and soy. So these same culprits kind of keep showing their heads over and over again. I didn't give the whole table, but it's interesting how many animal proteins kept showing up on the list. So milk, egg, poultry sometimes. So here, I'm going to kind of speed through this table, but looking at the predictive values of testing. So prick testing had a greater than 90% negative predictive value. In other words, with a negative prick test, you could have a lot of reassurance that they probably don't have EOE based on that particular food. The one exception, of course, is milk. It keeps coming up as an exception. So the negative predictive value for milk was 30%. It's actually worse than flipping a coin. If you look at the positive predictive value for prick testing here, it's also about the same rate as with the flipping a coin, so not very good. If you throw in patch testing, this thing work? Throw in patch testing, you're not getting much better. So the take-home here is that our standard tests are pretty good at ruling out food allergy, which maybe has some utility. They're not very good at ruling in things. And just based on experience, milk may just be the best thing to start with. So let's talk about reintroducing foods. From experience, and this is Matt Greenhot's review in the In Practice journal from earlier this year, and he talked about his experience and in the literature about reintroducing foods where peanut, tree nuts, seafood may not actually be playing a huge role in EOE, knowing that when they reintroduce these foods, they don't have a lot of reactions. The one caveat being that there are patients who have true IgE-mediated allergy to these problems or to these foods, and you might want to be careful you don't have any anaphylaxis in your clinic. Based on this information, he thought about maybe just narrowing it to a 4-food elimination diet, that being milk, egg, wheat, and soy. It's a little more palatable, I think, than the 6-food, but in a way it's kind of the same because a lot of these families, particularly in children, aren't really giving egg and seafood, I think, in many cases. So he put together a sequence for reintroducing foods. In kids, he talked about seafood first, nuts, soy, and then ending with milk as the last food to reintroduce. Whereas with adults, you would end with wheat. There's not really any data behind this, but it's just a proposed mechanism.
You wouldn't do that if they had skin test positive.
That's a great question. You know, do you believe the skin test, or is it? I don't know the answer to that.
And the other thing is with the milk skin prick test, does anyone actually look to see whether, when that's commercially made, whether it might be actually missing some key?
That's a great question.
Yeah, which component of
You
milk
know.
protein is there? Has anyone looked at the different? Are the milk hydrolysates okay if we feed Nutramigen or something?
You know, that's a great question. I think it depends on the patient. And there are patients who are sensitive to hydrolysate formulas. And anymore, I feel like if a patient gets to me, they're probably going to need to go beyond hydrolysate. It seems like there are that small percentage of patients who have sensitivity to all milk proteins need to go to an elemental formula. That's just based on my own experience. But one of the questions I always ask myself is, should we actually be using fresh extracts from the most common foods? And that's on my list of things to do.
Yeah, I mean, this is a little far afield, but it makes me wonder, why do some people who have positive skin tests to foods, some have anaphylaxis, some have eczema, some have EOE, and some have nothing? They have clinically normal and they're positive. which shows almost how useless it is to do food skin tests.
Don't sit out.
Clearly, yeah, useless.
They don't even understand.
It's 50%.
I mean, I think there's a subset of patients who are very atopic, and their birch skin test is like 20 by 40. You always wonder if they're eating those fresh fruits and vegetables that cross-react. Could that be an exacerbator of EOE? I don't think there's any good studies on oral allergy syndrome patients. Kind of interesting.
See, that's another thing. Some of them have oral allergy, have all kinds of manifestations, and the skin test is almost, or any test that we have, is pretty much useless in making a diagnosis.
I think I mentioned a couple of years ago, I have 3 adolescents, admittedly 3 patients, but these are all kids who are very birch allergic, typical oral allergy by age 8 or 9. And we tested them for a few, and these were with fresh foods, and they were, 3/5s, nothing exciting. They developed EOE when they were like 13. These were like 20/50. So and it was sort of out of proportion to their birch and grass getting worse. And so I of course did have them avoid all of these things stringently, and at least 2 of them had reasonable follow-up when they went back to the 3/5. So it's like, what comes first? Do you get this abnormal surface which intensifies maybe your response to those foods, which ironically,
One other point, and I'm almost embarrassed to bring it up, but when you get the tests that come in from the naturopaths, it's always milk, egg, and wheat, every time. So they're like 90% of the time it's those 3 foods. So the question is, does their test have any validity? Maybe it does, but I mean, it's always those 3 foods that show up on the
It
naturopath.
clearly shows when IgG goes up when you're eating it regularly. I mean, that's the Western.
That's like
No, but I understand that, but it doesn't go for everything. It's just those 3 keep coming out as the top 3.
Well, I had a patient had with EOE. Those were the top 3. The patient avoided cow's milk, for example, and then 2 months later, the naturopath repeated the IgG testing. And interestingly enough, coconut milk was recommended as a substitute. 2 months later, the coconut IgG was off the charts. The patient was clinically doing better. So you bring up a good point, and I think the silver lining with some IgG testing is that a lot of these patients avoid all this stuff anyway, and they end up feeling better.
Yeah, but it's just curious because we keep saying, what does this really show? And it's these same 3 foods all the time. So.
Hey, to your point, Paul, I agree in a way because it almost bugs me in a way that milk and wheat keep coming up empirically. And so there's maybe something to it. Just don't know yet.
Well, the other thing that's upsetting is most of those patients tell you they get better when they follow the advice of the naturopath, which could certainly be placebo. But
Sometimes they don't. That's why they come to you, because they want to see, right?
this is just embarrassingly unscientific.
The dairy farmers of America don't like this.
Neither do the wheat farmers.
I'm gonna rock through a window.
It's like the cow that says eat shit.
So a couple weeks ago, the Quadii Food Allergy group came out with the draft guideline for actually coming out pretty soon. And so they talked about EOE, some consensus or summary statements. And so they felt that in terms of gauging the long-term management of this problem, don't just follow symptoms and don't just follow endoscopy. And I hope no one's just doing endoscopy as the only way of following this disease. They felt it was worth checking for aero allergen sensitization, and I think even though it's evidence D, like the worst kind, there is none. I mean, I'm convinced there's several subtypes of EOE, and we're probably going to sort of map it out in the next several years, because we do see the patients have a seasonality to their symptoms. And then they talked a little too favorably, I thought, about serial EGD with biopsy as a way of managing disorder. And then I think it's very important to talk about nutritionist backup, and this is something I'm not very good about doing, I think, and I can do a better job. Because these are kids who are growing. They have multiple food sensitivities, and then we're also telling them to eliminate all these foods from their diet.
Kevin, what is the baseline, or what is known about the natural history of the disease? I mean, how many people get better? How like the time?
How do we know yet? We want to wager.
I don't know, because you see these various ways of guiding your avoidances, and they're all 80-90% getting better. And I don't know exactly what the time frame is, but certainly want to know how many are getting better without being treated.
That's a great question.
I don't think there's any. I haven't seen it.
Not yet.
Yeah.
Has anyone dared to speculate what's up with milk? I mean, if you're not having IgE to it or a T cell response, why could it, possibly be involved?
And why now?
Why now?
So just do people, most of the patients go on antihistamine? Is that actually a study that shows that does anything?
I see support for that.
Yeah.
I think it's important that we don't know. I mean, that's really the first step. And that's why
The
it's kind of
adults that present with dysphagia, those are the ones you can really know if they're getting better. I think the other ones that aren't quite sure, you do the skin tests and there's some positives and negatives, they will probably come back saying that they're much better. So perhaps it was never really real.
I really want to talk about eosinophilic GI disorders beyond the esophagus. That's kind of how I got into this talk. And these are much more rare. One author said there's been less than 300 case reports of, again, these are stomach, intestine, colon. The prevalence is on the rise, but we don't quite understand how many people are out there. Like we said with EOE, many patients are atopic, but not every single one of them. The natural history is also not very well understood. There's a lot of patients who have more chronic disease, waxing and waning, and many of them require chronic therapy. And one of the concerns from a pediatric standpoint is that there can be a delay in diagnosis. So what we might brush off as just a child with vague abdominal pain might actually have something going on under the surface. So the first is eosinophilic gastroenteritis, or EG, sometimes EGE. Symptoms not too dissimilar in some ways from EOE. Instead, though, we see sometimes more diarrhea, weight loss, and a real interesting feature is an eosinophilic ascites that can occur in certain cases. Like I said, the incidence is not really well understood, but it's far less common than EOE. Spergel goes out of his way in his review in 2009 to talk about EOE being a very, very distinct, different clinical phenotype than these distal problems like the gastroenteritis or colitis. He thinks that really there should be different treatment approaches. But as we go along, I think in a way there's actually a lot of similarities, only because we know so little about them that in a way we almost have to extrapolate our EOE knowledge into the distal problems. Interestingly, if patients have just isolated EOE, they rarely progress downstream to gastritis or colitis and so forth. But the opposite is actually not true. So if you have patients who have EGE, many of them will actually go up and have involvement up in the esophagus. That raises questions about could that actually have been Crohn's disease or something else that we detect. In terms of epidemiology, I can only find that maybe the third decade is the most common repeat or for onset this disorder. I couldn't get solid numbers in terms of male-female prevalence or age range. There's also no agreed histologic or diagnostic criteria for the disorder, and we don't know exactly what direction it's going. There are some categories of transient, persistent, and chronic intermittent, and some authors try to characterize one subtype of each of these disorders as having more of one time frame versus the other. I got confused in it. And then, like with EOE, patients can have IgE and non-IgE mediated symptoms. But some patients will have increased total IgE or specific IgE to foods. So when you talk about the gastroenteritis, it depends on the level of the involvement of the GI tract. So in the mucosal disease, you have sort of a skewing in medical journals. So you see most of the case reports there. These are very non-specific symptoms in some ways, but they do tend to sort of congregate around the part of the stomach involved. So you get early satiety, vomiting, more food, meal-related symptoms, whereas in the bowels, you see more diarrhea, hematochezia, iron deficiency, anemia, failure to thrive, so kind of longer-term issues. The muscularis level disease tends to be reported more in surgical journals. These are patients who have more obstructive symptoms from these hard, rigid, thickened GI walls, where you get more distension, nausea, vomiting, and sometimes patients will actually go to surgery for an eosinophilic disorder. Skipping now to subserosal disease, these patients have this ascites or an eosinophilic ascites, sometimes it's bloating, and they can also have involvement of upper layers too. Here's some images of the eosinophilic gastroenteritis. Here on the stomach antrum, you see this nodularity, and they call it polypoid mucosa. And then on histology, you see these sheets of eosinophils in the lamina propria. Not too dissimilar, again, from EOE. So the differential for eosinophilic gastroenteritis could be IBS, or IBD. So in Crohn's disease and ulcerative colitis, though, you don't really see that much peripheral eosinophilia, and usually not as much in terms of eosinophils in the biopsies. And then it's, again, same differential in terms of malignancies, vasculitis, and so forth. One interesting fact here I noticed about Church-Strauss is that many of the patients will have asthma for several years before their GI symptoms start showing up. So maybe something to think about. So this is a study by Chang in a GI journal from a couple years ago. And I like this because it's a snapshot in this disorder. This is a Mayo case series from 87 to 07. And these are patients who referred for EGE-like symptoms, allergic gastroenteropathy, and peripheral eosinophilia. They had 59 patients in total, so not a lot. This is probably the largest cohorts I could see. Almost all of them had the mucosal form. That's the highest layer of the disease. 3 with muscularis, level involvement, and 4 subserosal. They used a control group of patients who had just vague GI symptoms and happened to have peripheral eosinophilia. That was their comparator. And if you look here, I think some of the parts that stand out, I put them in bold. There's a lot of atopy in the mucosal disease. In fact, none seen in the muscular subserosal group or in this other, the patients who had the GI symptoms plus peripheral eosinophilia. What also stands out to me is the total IgE level. So these mucosal folks had total IgE present, as did the patients who had absolute eosinophil counts that were elevated, but not quite so much so in the other layers. So again, this is a more superficial form of the gastroenteritis, which seems to be more allergic, for what that's worth. They found that patients also had a lot of allergic conditions in the EGE group, so drug allergy, asthma, rhinitis, and so forth. There was a lot of drug allergy in this group. You can't help but wonder if these might have been just drug reactions causing the eosinophilia. But then here it is, they have a lot of food allergy and intolerance in the same group, so maybe there is allergy involved too. These patients were tested who had the EGE and not tested who had these other symptoms. Food allergy really wasn't the differential at the time, I think, in this cohort. So half the patients had no food allergy or no sensitization. Vegetables, interestingly, came up pretty high, grains, nuts, fruits, and so forth. So the authors in this snapshot, again, this case series of patients with EGE, they said that while many food allergies were identified, and I said positive tests, I'm not sure what say positive test means a food allergy, half the patients had negative testing, so what's the use? And they also brought in, being honest, what's the sensitivity of the test, and knowing there's a lot of false positives, can we really hang our hats on this? So really be cautious about applying food tests to patients who have the gastroenteritis form of this disorder. So in terms of management of the gastroenteritis, particularly if patients are symptomatic, we start with dietary elimination, empiric, test-driven, elemental diets, and this is very similar to EOE, to be honest. There is one report in adults of milk-only eliminations yielding results. And again, that's kind of like we saw with EOE. If patients do improve with food eliminations, then reintroduce foods every 3 weeks. And then there is some talk about treating environmental allergies, but I think it's kind of a stretch. I'm not sure if that's going to do much. There's no data behind that, really. So if the dietary approach fails, then it's time for anti-inflammatories. The new draft guideline from the QuadEI does support oral corticosteroids as the first line of therapy for patients who are refractory to dietary interventions. Again, evidence D, and that's just all across the board, it seems, as evidence D and C in making these guideline recommendations. Prednisone, 20 to 40 milligrams per day in adults. If you don't see improvement in 2 weeks, or if patients relapse quickly after they're treated, maybe time to talk about very low-dose chronic therapy. So far, there's no evidence to support montelukast or cromolyn. And this is a newer therapy I just noticed. It's called Euceris. And what it is, it's a coated form of budesonide, and it's time release based on the pH, actually, of the area of the GI tract that it's in. I believe they have an indication for ulcerative colitis, where the tablet dissolves at 7, pH of 7, and it gets to the colon. So the idea is that you can actually hit the areas that are affected. They have this controlled ileal release form, and I don't think it has a brand name yet or trade name, and I'm curious to see what they'll call this, but this is more for Crohn's disease, and I think they can kind of have targeted target the various parts of the GI tract to help target the problem where it's at. And I think there's actually maybe some promise for this for our patients who might have these disorders, because it'd be helpful to just get to the area and not do systemic therapy. So in terms of long-term follow-up, what do? Do you monitor just GI symptoms, the abdominal pain, bloating, so forth? Do you follow just the peripheral eosinophilia, if they have it? And is there a role for monitoring specific IgE or total IgE foods? Do you do repeat endoscopy? I don't know the answer to that. In the time that's remaining, I want to sort of zoom through eosinophilic colitis. This is really two diseases, I think. You have infants who have a very specific course, and then adults. The infants are usually diagnosed on average around age 60 days of life. They tend to have more of the bloody diarrhea type and less of the systemic symptoms. I learned it as cow's milk protein intolerance, but I like to call it allergic proctocolitis of infancy. So very bloody stools, particularly a few weeks after introducing a new formula, whether it be milk or soy. And by the way, milk and soy are the two most common culprits. So much so that if a baby fails cow's milk formula, they really should skip over soy and go to hydrolysate, and in some cases, the elemental formulas. That's to say, though, there are other foods that are possible triggers for this disorder, and I think I've made a mistake in the past of assuming it's only milk and soy, when in fact there might be another food, and another food that's being transmitted through breast milk. Speaking of which, there are reports of more of these problems in babies who are exclusively breastfed. So my thought maybe is that they're getting exposed to more proteins through breast milk. And then it can be reported, Len's question earlier about hydrolysate formulas, these patients can actually get this disorder with hydrolysate formulas, so the idea is that maybe they're still sensitive to small amounts of slightly intact milk proteins. And interestingly, there is discussion this is an early form of FPIES, or food protein-induced enterocolitis syndrome, and that's actually a fascinating thought, and there's a lot of crossover. So in the kids who have or the babies who have this proctocolitis, it's a very benign condition. Over time, they get better. Just eliminate the food, milk, the soy, maybe another food from the diet. Also, mom's diet if they're breastfeeding. And then the question is when and how to reintroduce, and that's maybe another day to talk about. But my theme has been maybe at a year or 2 years, slowly introduce a little bit of cow's milk and see if they can tolerate it. I haven't done it enough times to tell you how it works out.
So do you detect the eosinophils in these kids, either the blood or the stool?
These kids usually don't get any kind of studies. It's a clinical diagnosis in most cases, and so that's a great question. My assumption is maybe yes, some. If you extrapolate, though, from the adult course, here you have more systemic symptoms. They do end up getting more endoscopy, whether it's EGD or colonoscopy. They do have eosinophils in the rectum and in the colon. These patients are not, first of all, they're very rare and they're not understood very well. Very rare to see food or IgE involvement, so it's almost not even worth testing for them. These patients, because they have this chronic and relapsing course, most often are on systemic steroids, and in some cases need azathioprine or 6-MP to remit their symptoms. So far, cromolyn, montelukast, and histamines don't have any role in this condition. And in terms of long-term follow-up, you might look at AECs or endoscopy on a routine basis. But again, there's so few patients and so little reported, I'm not sure if there's consensus on what to do with these patients. I'll kind of buzz through this, but this is a great review, also in the In Practice journal. This talks about FPIES, and this is a fascinating condition. I feel like I've been seeing it the more I look. And classically, it's babies who have this very, very profuse vomiting, lethargy, usually 1 to 3 hours after eating a new food. If you break it down, milk, soy, rice, and oat. So milk and soy, it's very familiar. We talked about that with the proctocolitis. When you break it down by liquid, so milk and soy FPIES starts early. These are babies who are on most often milk and soy-based formulas, so they're going to show up quite early on the radar. Whereas the solids and rice, in my experience, rice has been very common. I've seen babies with rice-oat combination, and then anything down the list there can be a trigger. A parent came to me and actually talked about her experience with the primary care not noticing this disease, and she said, my baby has FPIES. And the doc said, well, maybe, maybe not. And she went and reintroduced rice and oat, and her baby in the exact same clinical set of symptoms showed up. And she went to a website, and there's actually a parent group that's surveying all the parents with FPIES, and they actually have some interesting numbers in terms of what foods play out here, and I think that may be the largest case area, or the best feedback we have about this disorder right now. Of course, the self-reported, so you don't know the reliability there. So, FPIES is mostly boys, and a lot of them have atopic disease, but we don't know where this comes from. You have negative allergy testing. Are these T cells? Don't know yet.
You brought this up in the context of the talk about eosinophilia. Is there eosinophilia in that?
We don't know yet, because again, these babies don't often get endoscopy. What they're getting often, though, is workups for sepsis, a lot of sort of...
No peripheral eosinophilia.
Not that we're aware of yet, no.
It's just in the babies.
It's just in babies. I mean, sometimes you'll see it in older kids. Have you seen it?
Yeah, well, don't you hear the story of the person who eats fish and 2 hours later they're vomiting? Sometimes it happens with shellfish. So there are case reports for adults. And when you test them, they're negative. You do skin tests, RAS, they're fine. You tell them, oh, you're fine, you don't have an allergy. And then they go home and they do the same thing. I mean, I had a patient, she was probably a 16-year-old girl. But there's FPIES in fish. Fish and shellfish for adults. But you think of it mostly for babies.
You know, it kind of makes our brains explode, though. You talk about these delayed, non-IgE. It's like the alpha-gal. What do you think about that? So the draft guideline also talks about the management in terms of nutritionists. And, again, they talk about PPIs, beware of side effects in growing children. And then, again, I should probably think about this more myself, looking for calcium and vitamin D supplementation in patients who are on milk elimination diets. It seems like everyone in this category. Feeding dysfunction is also a problem. Look at the study. A lot of patients had these learned maladaptive feeding behaviors. So food refusal, grazing, just kind of a lot of prompting to eat, just not interested in food. And a little bit sort of saddening about this is that as patients got better, a lot of these same behaviors persisted through their wellness. Let's talk about the cost of formula. Formula is theoretically a nutritionally complete approach to feeding patients who have severe food sensitivity and EGIDs. Indications are things like milk and soy protein allergy, patients who have FPIES, EOE, different conditions where they can't tolerate foods and need to rely on completely hypoallergenic formula. I went online and compared costs, and if you want to go buy just a crate of Kirkland Signature cow's milk formula, it's going to come out about 50 cents per ounce. Nutramigen, which is one of the cow's milk hydrolysate formulas, is just under $2 per ounce, and then Neocate, which is one of the amino acid or elemental formulas, is over $3 per ounce. So that's 6 times more expensive to buy the elemental formula. This is actually some numbers I borrowed from a parent advocate whose son went through a bout of eosinophilic gastritis. And the point here is that not all insurance will cover elemental formulas. They're carved out as a special medical food category. And what happens is, in many cases, private insurance won't cover elemental formulas unless they're given through a tube. And so the logic there is that patients need to have a G-tube and all the expense and morbidity that goes along with that in order to pay for the formula. So in this family's experience, it was around $1,000 to $1,500 per month to feed a 3-year-old out of pocket because their private insurance wouldn't cover it. Curiously, the insurance, there's a mandate for PO formulas to be covered for phenylketonuria, but not these other conditions. So the reason I got involved is that there was a bill, they asked me to testify in Olympia, and this basically would require private insurers to cover elemental formulas for PO feeds in patients who have EGIDs. There are states that already have these laws, and Washington's hoping to join them soon. So the patient I brought up at the very beginning, he looked back at his EGD and biopsy. He had thick sheets of eosinophils in his gastric lamina propria. Above and below the stomach was fine, so he probably had eosinophilic gastritis. So with various food eliminations, he did a little bit better. Of course, he likes the milk-only elimination, and this put a cramp in his style as much. But he admitted that he felt best when he took prednisone. And so that kind of gives us some clues that maybe this might be backup in ways. His anemia and weight started to improve. And one interesting feature, though, is his eosinophil count still hovers around 500. So where these eosinophils are coming from, whatever's making them upset, they just haven't quite gone away yet. So the question here is a long-term strategy for this patient. You know, he's leaving for college at some point. Do you use steroids as a backup? Do you follow with lab tests? I mean, how do you gauge his progress? I think he's doing okay, but not great. And I try to balance in my mind the use of steroids versus his clinical course.
What's the significance of the microcytic anemia? Is that just blood loss?
It could be blood loss. It can be poor absorption. You know, I think it'd be important also to rule out things like, you know, IBD in a patient like this. I think presumptively his endoscopy didn't suggest other conditions. But yeah, there's a lot of questions about this.
Did he continue on prednisone?
No.
Did not.
I feel like there's a lot of worry with enteric steroids, but is there any real evidence that they're harmful? I mean, the idea with budesonide is it's not absorbed, right?
Right.
I mean, are we seeing other, malnutrition or other issues secondary to them?
I'm not aware of any. I mean, I'm sure there's problems out there, but when you use... I always wanted to invent like a steroid dip. You know, you can put our patients in it and take a deep breath, it's just all their problems, but instead we use, small amounts of steroids here and inhale a small one there. But why not use it in the gut too? That's why I'm a little excited to see what happens with these newer products, especially if the time release, to get the exact area that's involved. Because, I mean, as Gary would say, you can treat this patient with prednisone, and they're going to be happy and feel better, but then what are the long-term consequences? He's only 17.
But you didn't try enteric steroids, right?
Not yet, no.
Doesn't the pH would change though if you had a lot of inflammation, or then you might wonder whether that would go to where it's not.
That's a great question. Anyway, these are my summary points. I'll let you guys keep them. We're done on time.
Kevin, have you found that the GI guys want to unload these patients on you as fast as they can? Which is what's happening in Everett. As soon as they diagnose them, they don't want to see them back. They don't want to do anything.
The trouble is that I knew that our skin testing was useless, and it stopped sending them.
And I think they still want to get rid of them.
Yeah, it's the management.
Did you still encounter GI who were non-believers? I feel like some still think...
I think they're non-believers until the biopsy comes back, and then they just want to get rid of them. So I don't think they want to manage them anymore.
That's right.
I feel like we keep telling patients, or at least what I do is tell them, well, we can treat it aggressively or not, but we can kind of see how it goes. Because we say, well, we don't think there's any bad long-term effects like you see with untreated reflux and Barrett's esophagus. I mean, do we know that this doesn't cause cancer long-term?
Exactly. I think about that too.
Have there been any reports that you saw? Or?
There's not a longitudinal data right now.
No. I mean, it's only like, at the very worst, I don't think there's cancer risk, but it's more, stenosis. You get dilated.
Yeah, that's what's often reported.
Matt, this direct question I tell parents, I said, we got 20 years of safety data with nebulized budesonide today. That's way more steroid than you're going to get this way, so I really wouldn't worry much, and they usually will buy it. You can't say anything about prednisone. Don't even bring it up. It's like, no, we don't use that.
I wouldn't.
Next week, we have an excellent guest speaker, Jonathan Foran from UCLA. We're talking about cytokine therapy.
Very cute. I'd get a box there.
Jerry,
I don't know.
Patient I want to talk about putting on Xolair with EPA failed all the antifungal therapies and can't get off high dose steroids.
I have actually a lot of people want number.
Yeah.
I don't know.
I have probably in the office.
I think I'll make comments. I want to further. I want to see if you have the good vaccine response.
And then I have two people with angioedema coming your way that I can't figure out. So it's just nice having you looking over my shoulder to make sure.
Actually, I have one woman I was like 206, 29. I have no idea what it means. Nothing to be surprised. But I think it would be nice if
Is there deadline to sign up or somebody else?
so I was just thinking about doing a 2-week Aaron's there as well. Aaron.
And how's Bart doing?
Good.
He had a good weekend with us. Let me know when you can stop over. I was at the You find it interesting? I haven't looked over his record recently, but